for being here. I am super happy to be having this conversation. It is such a sobering moment for me as a person who has fall into being complacent many times when it comes to COVID, and to be, it's so easy to end up being careless for ourselves and for those around us. So this is such an important moment to have a reminder of how much of a pandemic this continues to be, and how important it is to be aware of what we're going through as a community that goes through a pandemic together, right? Because we have gone through this pandemic together, and we have to continue going through it together. I actually this morning in the New York Times, which I'm not saying the New York Times is the best outlet for news, but in the New York Times was a very interesting article talking about how 20 and 30% of people who get COVID get some cognitive impairment several months later, including people with symptoms that are from mild to very strong, and affects their cognition, and it was really remarkable to be reminded of all of these. But I am not an expert. I am just a person who went through COVID a couple of times, who experienced symptoms of long COVID. And I am a person who really didn't know that those symptoms were long COVID, right? Why am I so foggy? Why do I need to double up on my ADHD medication, right? Why I can't pay attention to things for more than 5 to 7 minutes? And then I realized that this maybe and most likely is long COVID. So we're going to be having this conversation today, but we have experts in the room. One of them is my dear friend and one of my favorite persons in the whole world, JD Davis. So gorgeous. Hi, gorgeous. Hi. Do you want to tell us a little bit about the work that you do and who you are before you start with your presentation? I know everything about you, but I don't know if everybody knows.
Sure. I'm JD Davids. I'm here in Brooklyn, which is Lenape, Canarsie land, and I'm a chronically ill and disabled trans queer person who now has long COVID. And I'm the co-founder of Strategies for High Impact, which was founded by two transgender non-conforming disabled and chronically ill people. And we run long COVID justice to fight with, as, and for what trans people need. So I'll be talking in my presentation about some of the things we're doing and some of the things I feel strongly about. Should I hit it?
Yes, hit it.
Okay, I have some slides. So am I authorized to share slides? Do I have the power? Yeah, I have the power. I'm very bad at sharing slides, so I'll tell you that in advance, but I'm gonna give it a go. Okay.
And since we are waiting, I'm going to add a description of who I am. And I am a light-skinned Latina with long blonde hair and yellowy clear glasses and a black shirt with some kind of design that is with red and white. And in the background is two doors and a chair.
Thanks. And I am a pale white person with a blue-black mullet hairstyle, wearing a cute gray piping bright turquoise tank top under an unbuttoned black collared shirt with a white stripe along the buttons and buttonholes with a pattern. And I've got big headphones on. So I want to thank everyone here from Trans Equity, especially Cecilia, who's also on the Long COVID Justice Advisory Team, Mateo, Oscar, and Stefa, and also to Cecilia, Sari, and Kay for presenting here tonight. And thanks to everyone at Long COVID Justice, especially Vula, who helped so much with my presentation and slides and is assisting in the chat tonight. I'm also grateful for everyone who is not here tonight, because you're taking care of yourself or others. Elder is the word I use for many of us who are chronically ill and accumulating and sharing the wisdoms of our lives. And when we're elders, often our work and our contribution is our resting, is our not doing, is our undoing the lies of the false binary of healthy and productive and giving and good on one side versus sick and incapable and needy and bad on the other side. As we know, as trans and non-binary people, all binaries are false. Because as we're reminded by those fighting in the caring economy, we will all give and all receive care in our lives. Caregiving, which is devalued as feminine, as female, as immigrant, as queer, unpaid or low paid labor, is actually the core of being human. When we care for ourselves, for each other, we're doing the work of being human, even if it's not the work honored by racist, capitalist patriarchy. So thank you for caring for yourselves, even if that means not being here tonight. As Cecilia mentioned, there's a lot to do. And in the New York Times this week, there was this piece. The New York Times is one of the media outlets known for minimizing COVID by, among other things, never really connecting in their coverage, rarely connecting in their COVID coverage, the chronic effects like long COVID. Young people, middle-aged people are experiencing trouble thinking, serious trouble thinking in huge numbers. So much care is and will be needed. So look at this chart. Why have we not been shown this chart? Have you got this chart from any LGBTQ organizations? Have we gotten it from our city health providers? Have we got it from our medical providers? If you've been feeling unwell long-term after having COVID, whether or not that COVID was confirmed by a positive test or you even were symptomatic, you may very well have long COVID. If you are having changes in your memory, trouble thinking or feeling foggy, that may be long COVID. It doesn't matter if people don't believe you, even if they are medical providers. As trans people, we know what it means to have people deny the realities of our lives and bodies. And that's happening all the time with people with long COVID. It's incredibly common. 6% of all adults in the US, not 6% who just had COVID, or 6% overall of the population of adults have long COVID right now. And 1 in 4 of us say it significantly limits our lives. This chart is from the US Household Pulse Study by the Census Bureau. It's run every 3 months. Every single time, except for that one little blip where we dipped below cisgender women, trans people have the highest rates of long COVID. And every single time, also, by the way, bisexual people have the highest rates of long COVID. We know many of us in the trans community are considered bisexual or consider ourselves bisexual, whether or not we identify with the term. So why is it that the rates are so high in trans people? Let's look at this list of risk factors from the Patient-Led Research Collaborative. Trans people, for example, are already more likely to be low income or have low wage jobs where you can't rest because you don't have sick days. That creates inability to rest in the early weeks after developing COVID. Add on that the stimulus checks were denied to sex workers, that often the last hired and first fired are trans people, and with all the shenanigans been going on throughout the pandemics, we see lots of reasons why the marginalization and bias against trans people puts us at higher risk of long COVID. It's often overlooked that a major risk factor for long COVID is already being disabled or chronically ill, and we know that we may be at higher risk for those things already. This includes conditions like connective tissue disorders and neurodivergence like ADHD, both which have independently been shown to increase risk of long COVID. Trans people can also face explicit and implicit bias and discrimination in services, including in disability services and disability community organizations. That's not a risk factor for long COVID, but certainly can impact us when we're trying to get support. So before I go any further, I'm going to ask you to reach out to us. You'll find all the contact info in our resource guide, which will be in the chat and in the links in this slide deck. And you can also email me directly. I'm jd@longcovidjustice.org. If you're in New York City, you can join Long COVID Justice NYC. We just got the release of a city council bill that will force the city to conduct a thorough needs assessment of long COVID. And we're running our own pilot needs assessment and action plan, the NAAP. We call it the NAP because who doesn't need a NAP? With support from New York Health Foundation and New York Women's Foundation. The NAP, because we're running it, is focusing on New Yorkers with long COVID who are 1, transgender, 2, living with HIV, and or 3, children and youth. Our working group on this is open to members anywhere, so please contact us if you'd like to learn more or to work together to push for a similar project where you live. We're also creating a whole set of health education materials on long COVID in English and Spanish to meet the giant need for information, including trans-specific information. Again, please reach out if you'd like to help. Because
JD,
we know,
can I quick interruption from the chat?
Yes.
There have been a couple requests if you could do a description of what's in the slide for people who can't see them.
Great.
I know you're reading most of the text, but that would help.
Yeah, in most of the cases, I'm reading text and there aren't images, but I will describe the images. This is titled Long COVID Lacks an Ecosystem. There's virtually no ecosystem for long COVID education, training, support, care, policy, advocacy, and services. So we know that deep ableism and stigma against illness and disability predates the long COVID pandemic across society, and even the groups that support queer and trans lives, and even, ironically, HIV organizations, where it can be stigmatized to be sick or disabled. Groups like Transgender Law Center that center disability justice are very much the exception, not the rule. The ending of almost all funding for COVID-related efforts this year, plus political division, means there's virtually no funding for long COVID. And even long, stable federal funding for things like HIV is currently threatened in this political climate, much less things like COVID. As trans people, we know when the public sector doesn't tell the truth about our lives and doesn't give us the information we need to do it to save ourselves and each other. But to understand and address long COVID, we need 3 levels of information and analysis, which is described on this slide. It says we need 1, facts and information, 2, support for turning this information into action, and 3, the advocacy that people like me and many of you do that pushes for more than the basics. But in this case, we're having to do all 3 of these levels. So that's why we need to keep working together. Please reach out if we can work with your groups, give presentations, ally on campaigns, and work together to do what we shouldn't have to do, but must, because our people are hard hit by COVID harms and long COVID. The next slide is called Confronting a Health Crisis in Trans Communities. We need to resource trans people and trans communities to care for one another in this health crisis. This is a flavor of some of the recommendations we're likely to have in our NAP. It says funders, public systems, and health care providers should, 1, train and hire trans people as community health workers, doulas, and healthcare providers to take care of each other, as we already do, but in good jobs with living wages, professional development, and advancement opportunities. 2, resource existing groups and projects that are accountable to and serving trans people to integrate long COVID outreach, information, care, and support, including medical centers, community groups, and HIV programs. It continues on the next slide saying, provide tools and education to expand access for disabled and chronically ill trans people to community support, events, services we're locked out of with the ending of virtual programs, masking, and other COVID prevention. Arm us with COVID treatments ahead of time, like Paxlovid, which has been shown to reduce rates of long COVID too, so we don't face bias and delays if we're sick. And provide access to promising long COVID therapies like low-dose naltrexone, LDN, that often aren't covered by insurance. And facilitate and fund agreements to craft practices to protect our communities from COVID infection and reinfection. And then the slide asks, and I ask, how can you help confront this crisis through your roles in and across trans and other communities? This slide is called Free KN95 Masks for Trans People. And this is what it says. We are working with Mask Block NYC to help get effective masks to people. We currently have up to 2,000 free KN95 masks to send to trans people and our families. So there's a link for the resource list in the chat that includes a link to a request form to request masks. You're invited, if you are in a position to make a donation tonight to Long COVID Justice that will help cover mass shipping costs. And we're also providing in our resource list information how nonprofits can request mass donations for yourselves. Next, I'm going to run through slides provided by the Patient-Led Research Collaborative, PLRC, which is founded and led by people with long COVID, to talk about long COVID symptoms and conditions. So I'll just say ahead of time, in most cases, I'm actually not reading the slides and I'm passing through them quickly. They're a resource for people to look at later, but we're also happy we could make an audio version of the content on the slides for those who would like to have them read to you. There's just not enough time to go through them. We also believe they're good tools to give to a lot of medical language. You can bring with you the medical providers that has links to the medical journals that are saying these truths. If you're a researcher or a policy advocate or other data-related person with long COVID, I hope you'll join me as a trans member of PLRC, that Patient-Led Research Collaborative. Please reach out if you're interested. Or also if you have a chronic illness or disability related to long COVID, you're also welcome. As noted by PLRC founder Hannah Davis, who worked on this paper that's listed here, Long COVID, Major Findings, Mechanisms, and Recommendations, long COVID is already one of the most studied illnesses in history, with 3 to 4 papers coming out on it every day. For this paper, we had hundreds of studies in the outline and had to narrow it down to 200. It's one of our pet peeves as patients when long COVID is described as mysterious or that we don't know anything about it, because we actually do. And these slides, that some of them have a logo on the bottom right from the Patient-Led Research Collaborative, showing that we got them from PLRC, although sometimes we've added some emphasis or changed a few things. So here's an overview. It has 9 bullet points, and I'm going to just mention a few. 10 to 30% of people with COVID will experience long COVID, including 10 to 12% of vaccinated people who get COVID. 75 to 90% of long COVID cases happen with people whose acute affection, when you first get sick or have COVID, is mild. Now, people may be more likely to get long COVID if they have severe COVID cases, like they're hospitalized or very, very ill. But there's far less people who end up, who have severe COVID. Long COVID is pretty common, including in people with mild cases. So the vast, vast majority of long COVID cases happen with a mild initial infection. However, that long COVID could be mild, moderate, or severe. It could be coming and going. It could start right away after first getting sick, or things could appear months later that feel and are very different from what initially happened in COVID. Symptoms last for years. 2 of the most frequent conditions seen, ME, CFS, and dysautonomia, are currently expected to be lifelong. It's also vital to recognize that children and youth do get long COVID. In fact, they may be even less likely to be believed. Younger children use other words and ways of describing symptoms, and adolescents are labeled as being dramatic, resistant, or going through growing pains. Prior infections can increase risk. That means reinfection. Getting COVID more than once increases your risk of getting long COVID or getting it worse than you already have it. This slide is called False, quote, there is no treatment for long COVID, unquote. There is no single treatment or cure that can reverse long COVID in all people. But there's many symptoms and conditions that are in long COVID that some self-care and treatments can help or prevent further harm. Many of us with complex chronic conditions like long COVID know our lives can be much improved by treatments and care, even if we're still sick and disabled. However, many medical providers don't know how to treat the most common long COVID conditions. And some treatments can be expensive, especially if we're taking many over-the-counter agents and or those not covered by insurance. We believe treatment will continue to get better in the years to come as well, as we fight for the research and support we need. And we are fighting for trans inclusion in the research. The next slide is called COVID and long COVID increased rates and risks of chronic and or dangerous conditions. Both COVID and long COVID increase risks of well-known conditions like diabetes or heart problems that medical providers are more familiar with. Our society is far less healthy now than 4 years ago, and even young people are at higher risk of potential sudden and fatal conditions like heart attacks and strokes. All of us, if we can, would be well served to get sort of thorough physicals and checked out after we've had 1 or more cases of COVID. And we should have to be really on top of, if you think something might be wrong, it very well may be, and it could be serious, and get checked out if you're worried. The next slide says, symptoms can happen right away or later. People may have worse or new symptoms a year later, and many remain sick long term. There are some patterns identified as far as what symptoms may take longer to appear and which ones may resolve or improve versus not. Again, I'm not reading everything that's on the slides. It'll be available as a resource. This is a chart of some of the common long COVID diagnoses and comorbidities. A comorbidity means an illness or condition that occurs alongside others. It's sort of fellow travelers. Next are slides for each of the complex chronic conditions that are not well known by medical providers, yet very common in long COVID, including links for more information for patients and providers. Again, I'm not going to go through all the details because we're going to give you the slides, but we're happy to talk about all of this further. The first is ME, myalgic encephalomyelitis, misnamed chronic fatigue syndrome, which is also known as ME/CFS. This may affect half of the people with long COVID. It's also both of the founders of long COVID justice have ME prior to long COVID and now also have long COVID. It can present in a lot of different ways. And sometimes we think, oh, I don't have fatigue. It's been shown in ME, there's 5 different kinds of fatigue. And I've had all of them at different times. One of them, it feels like being extra wired. Another one feels like having the flu. So sometimes we may not even know we have fatigue because we're not sure all of what that can mean. Exercise and any exertion can harm many people with ME. So doctors, family, caring friends may say, you've been laying around too much. That's why you're tired. You're deconditioned. You need to exercise. That can harm, even though many medical people push on others. Please learn about pacing and resting from the resources we provide. ME Action is an advocacy group that talks about stop, rest, pace. So if you search for ME Action, stop, rest, pace, there's great information there. Next is dysautonomia, which is a number of types of conditions. One of the most common is called POTS, which is POTS, it's an acronym. Dysautonomic conditions include different conditions that cause a malfunction of the autonomic nervous system. That's the nervous system that does stuff we don't think about, like our heart beating and our blood flowing. So it can result in lightheadedness, not being able to sit up or stand, fainting, blood pressure shooting up, shooting down, hearts racing. It can also bring about malnutrition and in severe cases, death. But there are things you can try that we may get without even going to the doctor, although it's good to access professional care for dysautonomias, like a high salt diet and compression garments, like a binder, but for different parts of the body. So please look at our resources so you can get more information. The next is MCAS, MCAS, which stands for mast cell activation syndrome. It may affect many people with long COVID and can include something called histamine sensitivity. Mast cells are all over our body, so when they start going haywire, it can create a lot of different kinds of systems that we may not know are related. Things like itching, rashes, digestion problems, allergy type reactions, and it can become severe, require emergency care. But there are treatments, even though MCAS was really first only recognized in 2007, so we've got a ways to go. There's a lot of over-the-counter stuff, like different types of antihistamines. There's dietary stuff, like low histamine diets. I freeze my food when it's left over instead of the refrigerator, so that lowers histamines. There's a lot of stuff we can do, and we've even thought about having like cooking clubs, for those of us with MCAS to be able to cook food that's good for us and store it together or something. So there's more information here. And then the next series of slides I'm not going to read, but it's information from scientific literature with links about what tends to happen in people with long COVID in the first 2 years. And it's important to note that after 2 years, only 9% of people in the studies reported a full recovery. We know it's likely these studies also didn't include many trans people who may experience the most barriers to the care that can improve chances of recovery. However, we do think that, care is going to improve because we're going to fight together to make sure it does. So next, vaccination. One of the few times you may hear the government talk about long COVID is to encourage people to get vaccinated. We do support vaccination, including telling people about the third COVID vaccine, which is called Novavax. It has lower side effect rates than Moderna or Pfizer mRNA vaccines and may offer broader protection. In our resource guide, there's information on how to get information on getting vaccinated. There's a free federal program called the Bridge Access Program to get vaccines to people who aren't insured. So this slide that says vaccination doesn't meaningfully prevent long COVID emphasizes that most studies show vaccines only lower risk of long COVID by a few percentage points. My time is almost up, but we have to talk about a hard topic: community responsibility in COVID prevention. First, let's look at the facts. This slide says reinfections not safe can lead to long COVID, prior infections not protected. This PLRC data slide has data on reinfection and long COVID and a lot of links saying that getting reinfected with COVID increases your risk of long COVID or worsening existing long COVID or other conditions. Long COVID is caused by COVID infection, and COVID infection rates remain high, even though mostly not reported. The government basically says they don't have to try to stop COVID anymore, since less people are dying and some people can get treatment, like Paxlovid, which can reduce rates of death in those most at risk. So we have a big challenge. This slide says reinfection and long COVID, a community challenge. It has the words I'm about to say, plus a graphic called the Swiss cheese COVID-19 defense method. And it looks like stacks of Swiss cheese that are layered on top of each other. So one hole is blocked by cheese on another layer, and talks about methods of protection that support one another. Trans people with long COVID should avoid COVID reinfection if at all possible. And we also know it brings risk to our community members who might not have long COVID yet. Since long COVID is airborne, an important way to stop reinfection is for our household and community members to also avoid long COVID reinfection, if at all possible. The most effective way to do that is masking, as well as using other layered COVID protections like airflow and air filtration. We are often failing this community challenge, as is much of the rest of the society. Don't believe the misinformation that masks don't work. This slide is called, "We're told who to be angry at, not what to do to care for each other." And I'm going to read what it says. Across the years of the COVID pandemic, we have not often been told what to do. Instead, we've been told who to blame: unvaccinated people, Trump voters, and implicitly, people at higher risk of severe disease and death. I'm not going to replicate that by saying I'm angry at those not masking inside public spaces and community events. All of our situations and all of my emotions are far too complex. The government and media and the vast majority of our organizations act as if one-way masking is enough to keep people safe. That means, people who want to wear a mask can wear a mask, even if others around them aren't. We've all been misled and misserved. It's expressed as a matter of choice. Quote, "I can choose to wear a mask and you can choose not to." But the truth is more complicated than individual choice. Many of us are among the 10 to 15% of the population. Many of us among the 10 to 15% of the population who are still masking are isolated. We miss you, and we miss each other. Because COVID prevention is long COVID prevention. COVID-19 is that's the name of the slide, and I'm going to read what's on it. COVID-19 is airborne. It travels similarly to smoke. N95 and K95 masks are extremely effective at blocking airborne particles. Masks are far more effective if there are high rates of mask wearing, not one-way masking. That means those who are the most at risk of COVID harms are wearing them, and those who don't see themselves at risk are wearing them too. If we want to protect each other, masks are key. If you are a person with long COVID, this is an important tool to protect yourself. Surgical masks, those loose ones that are often blue and very cheap, are better protection than nothing, but far less protective than N95 or KN95. There's also nasal sprays and mouthwashes with ingredients that in the lab studies, they do protect against COVID, but we don't know if they'll be protective in humans yet. And they may also reduce the impact of COVID if you do get it, if you're using these. But there's very little data, but some of us are choosing to use them in addition to masks. Opening windows and using HEPA filters can also help. We can protect each other and fight structural injustices, as this slide says, and I'll not read it. Our lives should be, there are ways we can protect each other. For example, Southerners on Newground, SONG, the queer and trans group, is having their retreat this week with a great set of protocols for COVID protection. We're collecting more examples. Send us your ideas and experience and we'll add them to the resource guide. When queer or trans events do not have or list COVID precautions, or say they will require masks but then don't, what are we saying to those who need to avoid COVID reinfection or who do not want to get long COVID? We also need to recognize this is a structural injustice. This slide says, COVID minimization is a structural injustice. Our lives should be flooded with free, easily accessible, high-quality masks and with healthcare for trans people. Without these things, there's a lot of pressure on us to uphold public health and justice, but it's still something we can work to do. Trans people have harder consequences of getting COVID due to higher rates of long COVID and all the challenges of getting care and services in a biased, discriminatory society. Rather than abandoning us as individuals and setting us against each other over masks, we need resources, guidance, tools, and funding from the government, from foundations and donors, and from public health leadership, and inclusion and help from LGBTQ organizations, HIV groups, left and progressive groups, and others who seek to honor trans lives. Strategies for High Impact and Long COVID Justice joined What Would an HIV Doula Do to create a series of Instagram tiles and linked resources to encourage the conversations we need to have on this. We asked, who do we cherish and practice with? Who do we care for, with, about? How do we navigate conflicting needs? And what is a need versus a preference? So I'm not going to go through these all, but I'm scrolling through these slides, which are available on Instagram and the Strategies for High Impact website. And they're available for individual conversations. We can come and facilitate discussions or workshops on them. And they link to specific resources and materials to help us look at these challenges of inclusion in the time of COVID. You can bring masks back into your routine. We'll get them to you, in fact. We're asking, that's what that slide is called. It has a picture of a mask next to it. We're asking you to mask in public spaces indoors and in community events so you don't get COVID or worse of long COVID. And frankly, so more of us can be with you. Mask Block NYC has masks to send to trans people from this webinar. Use the form we provided and also reach out to your local mask blocks for more. There's a list of COVID advocacy groups linked in our resources. If you can make a donation to Long COVID Justice tonight, we'll use it for shipping masks. The COVID Advocacy Initiative is fighting for masks in healthcare and other vital spaces. So see our resource list to get more information, get involved, and ask our community orgs and funders to provide masks and funding for them. I'm going to wrap up with this recent Instagram post from my beloved comrade, Pato Hebert, who got long COVID in the first wave of the pandemic and is on the advisory team for Long COVID Justice. There's a picture of Pato that is tinted blue. He's wearing a mask and has his sleeve rolled up. It looks like maybe he just got an injection. And he is at Volandito, if you want to find him. From family, blood and chosen, to colleagues, to compas, to strangers, so few folks in my able-bodied worlds even mask anymore. I used to be one of you too, back in late 2019, early 2020, and all of my ableist decades prior. But some of us can't live unmasked so consistently and still hope to optimize our health and yours. We try to mind what we might not even knowingly pass on or receive. We crip care for one another and everyone else too, our collective selves. We layer up as best we can. Throats and nostrils coated with protective sprays, mouthwashes, and gels. Masks donned despite all of their challenges to asthma, comfort, and easily radiant toothy smiles. jabs and boosts when we can access them. My eyes can smile too if one is attuned enough to tell. Please remember us when you're protesting, gathering, commuting, sharing meals, caring, despairing, dreaming. We do and want and need to do these things too. And we do this together as best we can in our own fantabulous ways, in the ways that we must, with disability justice as the shared air we struggle and endeavor to breathe. Here in the global north, winter is coming. Thank you.
Oh, thank you. Thank you so much, JD. I have so many questions, but I am going to wait a little bit until our next presenter is done so we can have a conversation, the three of us. Also, folks are being extremely communicative in the chat, which is always so good to see. That people are engaged. All of this information is remarkably new to me, and I feel like a little bit ashamed to say that I have not done as much research as I should have, and I'm learning so much from you, and I'm really happy to be in this conversation. But I am going to introduce our next presenter, Sari Reisner. Hi, Sari. How are you?
I'm great. Thank you so much. Yeah, my name is Sari, and my pronouns are he and him. And thank
Sari,
you so much.
Can you tell us a little bit of who you are and what you do?
Yeah, absolutely. So I'm located in Boston right now. I am a researcher. I was trained as an epidemiologist, and I'm at Harvard Medical School and Harvard School of Public Health. And I also work at Fenway Health, which is a community-based organization in Boston that sees more than 5,000 trans and gender diverse people every year for care. I'm also a transgender man, a white transgender man. I've got dark hair, glasses, and I look a little bit like the Verizon guy, if folks watch TV.
I love that. So take it away.
Okay, perfect. I'm trying to share my slides, but unfortunately I'm not able to. I was wondering if somebody could give me the permission that I could do that. There we go. Okay, excellent. Well, JD, that's a tough act to follow. Thank you so much for all that information. I learned a lot, and that's why I love doing this. So I'm really excited to share some work that we've been doing, some research that we've been doing, and JD did collaborate on some work. This is a study that we did with some colleagues, and this is the wonderful group. It always happens in research. What I love about research is when we get to do it together. So this is a team that I've been working with Dr. Andrea Wirtz at Hopkins, Marissa Miller and Carter Brown, both leaders. Carter Brown runs BTAC, Black Trans Advocacy Coalition, and Marissa runs Trans Solutions in Indiana. Tonya Petit, Dr. Tonya Petit, who I think is on today, is at Duke University. Dr. Beckham, who's now was at the Trevor Project, is now doing some consulting, and Dee Adams. So this is just a great project team. And what we did is we did this sort of emergency study. Now, basically, JD took all that good stuff, so I don't need to go through all that. But what I do want to say is, for background, that one of the challenges that we have is the invisibility of trans and non-binary people in research, right? And part of that is because we have data that we don't have disaggregated or separated by different gender identities, because we still don't have, in many of our public health surveillance systems, data on gender identity that we present. So the household pulse survey, which JD showed you that really cool graph in the beginning, does show that the prevalence of long COVID is higher for trans than for cis women and men. So about 41% versus 31% for cis women and 22% for cis men. But there's a really small number of trans and non-binary folks in that study, probably a low response rate. So we really can't look like among that trans population to see the specific vulnerabilities that might be unique for our communities. So that's why we do other research like this that I'll show you, which is really focused among trans people. And so, being able to have the sample size or enough participants to be able to do that was part of the goal of this study. And we wanted to learn more about sort of like, well, first of all, what is the prevalence of COVID and also long COVID? Are there groups at higher risk that are experiencing burden and inequities among trans people? And then also, are there specific vulnerabilities that are trans specific? So one example would be, JD mentioned discrimination or anticipated discrimination in care settings. Another would be, thinking through gender affirming medical care, specifically hormone use. There are some data, not in trans people, but in cisgender pre and post menopausal cis women, that suppressing estrogen can increase risk for COVID severe disease, and enhancing estrogen can decrease risk. So, in light of some of those data, which we don't know much about trans specific people specifically, it's important for us to even look at things like hormones. So that's some of what we wanted to do with this. So I'll present this study was called Light Connect. And as I mentioned, it was a partnership, academic community partnership. I'll talk a bit about the just prevalence of SARS-CoV-2, which is actually the acute, severe acute respiratory syndrome coronavirus 2. That's what it stands for. And basically, that is a strain of coronavirus that causes COVID. So that's when you see that, that's what that is. And then talk about long COVID specifically. So what did we do? We did a study. It was a kind of quote unquote emergency study that we did between 2021 and 2022. It was an online survey that was cross-sectional. So it was a one-time survey. People could test for antibodies, which would not identify an active infection necessarily, but it would say whether they had ever had a COVID infection in the past. So any antibody resistance. We did a bunch of community engaged research strategies to kind of mobilize folks to recruit this sample. To be eligible, people needed to be age 18, identify as transmasculine, transfeminine, or non-binary, or have another gender diverse identity, reside in any US state or territory, speak English or Spanish. All study procedures were offered in both English and Spanish languages. People screened. If they were eligible, they participated and received an incentive of $40 for a survey. The antibody testing that was done was a home test. People did a dried blood spot prick. So they pricked their finger and sent it, the dried blood spot card into the lab. And it was $10 to receive that. And this was all the study procedures went through the institution, the IRB, the Institutional Review Board for Human Subjects Research, to protect participants from researchers, just to make sure that everybody was safe and all the research was ethically done. So this is a very busy slide, but it's basically describing the different measures that we asked, like the things that we asked about in the study. So we asked about COVID. There were some people who were tested for COVID who wanted to get tested, and some people who didn't. So basically we created a variable that was people who self-reported that they had COVID, people who had confirmation based on the lab that they had COVID, and people who said that they didn't have a known history or they had no confirmation that they were negative. We looked at chronic health conditions, demographics, vaccination history, and a lot of specific exposures, like I mentioned before, discrimination and hormone use. For long COVID, we looked at people having symptoms for longer than 3 months. So one of the things in the literature, if you see the different prevalences or how frequently it occurs, sometimes they define long COVID as 1 month, sometimes 2 months, sometimes a year. But the way that we define it was 3 months. And then we looked at some fancy regression modeling to do that. Don't need to talk about that. But I'm just going to give you a snapshot of the overall sample. So this sample was 2,092 transgender and non-binary people. There was a good spread. So on the far right column, this is a graph that I'm showing here. That's the sample demographics, is the percentages. So there was a pretty even split across the geographic regions. So for example, 36% were in the South, 23% Northeast, 17% Midwest, 25% West. By gender identity, 42% were non-binary, 27% trans-feminine, and 31% trans-masculine. About 40% of the sample were BIPOC, so communities. So we were really happy with that. We worked really hard to try to engage folks who were not white in the sample, since that is a group that we always need to completely hear from. And that's something that we've been wanting to do more and more of in terms of how we reach communities. So this was a first effort, I think. Better than we see that in a lot of epi surveillance. 17% were Hispanic or Latina. Educational levels were pretty evenly spread, and income, about 41% earned less than $20,000 a year. 23% were essential workers. We saw, because this was during the pandemic, we saw a lot of the pandemic effects in terms of the social factors that translated into economic challenges. So in terms of social impacts and economic vulnerabilities, 61% reported having lost income in the household during the pandemic. 42% were experiencing food insecurity. 22% had been unemployed or temporarily laid off, or 50% were currently unemployed. Homelessness was reported by about 13%. 16% were relying on public transportation during the time, and this was, during the COVID pandemic, when it was sort of actively in 2021. And 18% had inconsistent mobile phone access. About 13% didn't have any health insurance at all. Others had private insurance, public, or weren't sure. 8.7% had lost insurance during the pandemic. We also looked at different vulnerabilities. People were talking about chronic physical and mental health conditions. So in this sample, about 49% had one or more chronic physical health conditions. 82% reported having a chronic mental health condition, and 30% reported a disability that interfered with carrying out their daily activities. Overall, when we looked at COVID, it was about a 40% prevalence. So 30% self-reported and 10% confirmed in the lab. 34% were not able to test for COVID when they needed to. So this was something that we found where there were quite a few barriers to testing, and I'll show you a slide about that in a minute. 79% had completed full vaccination coverage, so the complete doses at the time. When we looked at the factors that were associated with having had COVID, on the left here, you can see I'm showing you, it's a very busy slide, but I'm showing you basically if the numbers are more than 1, that means it's an increased risk. So those who were living in the South, who had chronic physical or mental health conditions, reported food insecurity, and anticipated discrimination, had higher risk of suspected COVID. And those who were living in the South, who were non-binary compared to transmasculine, who were homeless in the pandemic, who had food insecurity, and who completed the survey during the Omicron period, they were more likely to have had confirmed COVID. So basically what we're seeing here is differences by geography. We're seeing differences by sort of chronic conditions, health conditions, and we're seeing differences by social determinants like homelessness and food insecurity and discrimination. One of the most common things around testing, there were many, many barriers to testing. And I'm showing a graph here that has barriers that included difficulty scheduling, didn't know where to get a test, concerned of being exposed to others who had COVID at the testing site, transportation difficulties, sites only testing people who were showing symptoms, like not actually just testing if people were wanting to get tested, fear of mistreatment or misgendering, cost or financial concerns, time, and other. And one of the things that we see a lot of these challenges, reported testing challenges in many populations. And in addition to things like scheduling and transportation, here we see that fear of mistreatment or misgendering at the testing site was a barrier that was reported by 37.9% of those who didn't test. So, that being a factor that's involved in people not testing is, the healthcare system and fear of mistreatment due to structural oppression that's happening in healthcare context. So we looked at long COVID. So among the people who had COVID, excuse me, the 40% of the sample, we looked and found that overall 38% reported, I already said that, sorry. 31.5% had symptoms that lasted more than 1 month. So, and that 10% had symptoms lasting 3 months. So basically, of the people who had COVID, 10% after 3 months were still having symptoms that were defined as long COVID here, right? So 10%, so 1 in every 10 people who had COVID in this trans non-binary sample. And what we see here on the right, I'm showing a graph that the highest percentage of long COVID was among trans masculine people, 12.9%, followed by non-binary assigned female sex at birth, trans feminine, and non-binary assigned male sex at birth. So there were differences by gender identity that we saw in the sample. We also asked people what kind of symptoms that they were experiencing, and people were talking a lot about fatigue, shortness of breath, body aches, difficulty sleeping, brain fog, headaches, joint pain, loss of taste and smell, and overall 91% were reporting multiple symptoms. So there's a plot here that I'm showing on the right, and it shows all of the different symptom combinations that people are reporting, and people are reporting multiple symptoms. So it's just what JD was talking about in terms of the constellation of factors of different experiences that people are having that are comprising long COVID. When we looked at who was more likely, or the factors that were more likely to be associated with having long COVID, it was older age, having at least one chronic condition. So, having already a chronic condition increased the risk of having COVID. We saw gender differences, like I mentioned, with trans masculine and non-binary assigned female sex at birth people having marginally higher odds than trans feminine participants. We looked at an association with hormones. So we wanted to see, were those folks who were on gender affirming hormones, are they more likely to have been getting long COVID than those who were not? And we didn't see any evidence to support that. We also didn't see any evidence if we looked at the interaction of gender identity and hormones. So for people who had a gender identity and were on a particular kind of hormones, we didn't see that as well. So that was important for us because hormones here were not associated with long COVID. And if we're thinking about treatment, its implication here is that, prioritizing gender affirming treatment for those who are on it is important. Nobody should withhold hormones for trans people, non-binary people who are on them who have long COVID. So that's an important piece here. And then lastly, at least one vaccination was protective. So it did not prevent long COVID, but there was about a 50% lower odds of getting long COVID for people who had vaccination. So I'm gonna really just, I'll skip some over these, but I wanted to say that there's, in terms of equity, and inclusion, we know, all of us on this meeting, how important it is that we collect gender identity data. I think this study really is one of the first to take a deeper dive to see some of the factors. And, also some of the things that, we're going to need to do to mitigate the inequities, to address the inequities that we see trans and non-binary populations facing, are a lot of the things that JD and the organization, the Long COVID organization Justice are doing, Long COVID Justice are doing, like rapid peer responses, providing material support to each other, social and mental health support, which really is all of us being here together, and other forms of mutual aid. So I'm going to stop here. Just want to really thank all of the participants who took part in this research, people who helped make it happen. There's a paper that published with the data on these that I have here. These slides will be available to people, and we have another one that JD is working on with us right now. So I'm gonna leave it at that. Thank you.
Thank you so much, Sari. I can't stop thinking now of all like the intersections of like, you know, my own experience. And, you know, for example, I live with psoriasis. And since I had COVID for the third time, my psoriasis had become nastier and nastier and nastier. And it's like something that doctors are not able to really give me an answer if my psoriasis got worse because of COVID. So it's so many things that we may be living with that have been exacerbated by COVID. So I can't wait to have a longer conversation with all of you in a panel with you and JD. But because we love joy and we love and art give us joy, and it's not an artist that I love the most more than Kay. Hi Kay, how are you? Thank you for being here.
Hi Cecilia. Girl, you thought I'd bring joy to this. This is gonna be hilarious. I know.
I said that art brings joy. If you bring like all the sadness, I'm here for it. Babe, I am here for all the sadness. I'm here for all the rage. I'm here for all the joy. I'm here for whatever you bring. I'm here for it.
Splendid. Was Cornette Oscar included? To begin, my name is Kay Ulandai Barrett. My pronouns are he, they, sha. And I'm currently located in the unceded and occupied land of the Lenape and Munsee Hoking peoples in New Jersey. For image description, I am a light brown, round, queer trans person with glasses and short hair. I have a black mesh collared shirt on, and I have COVID hair these days. So thank you for your patience. If some of us here are neurodivergent, spoonies, people with long COVID, you might be fogged out. So if you're in the chat, let me know if you're fogged out, if you're overwhelmed a bit with this amazing, necessary research. I'm gonna do something that I do to ground this space before I perform, and it's in the Filipino language, Tagalog. It's called the Isang Bagsak. The Isang Bagsak translates in English as the one witness, the one hit. So if I'm in a meeting with Cecilia, JD, Maxwell, I see Walela in here, and we come to a conclusion together. We do this as a collective when we are in meetings, protests, decisions. Think of someone right now who needs extra care and tenderness. That person could very well be an ancestor, a friend, or even yourself. Take a deep breath and just dedicate this time to that person. When I say Isang Bagsak, people can stomp, clap, or scream as they would like. Hey, I see my Pinoy flag, not to be nationalist. Ready? When I say Isang Bagsak, think of your person, and then you can stomp, clap, or scream. Take a deep breath, inhale, exhale. Isang Bagsak, first poem. This is a Sikh pastoral. Pastoral is about nature. It's a Sikh ecology poem. Sikh and disabled people are impacted by climate justice and climate catastrophe. I include climate talks in the mass disabling events that queer and trans people love to have without updated HEPA filters, HVAC, and 95s. So this is dedicated to two trans and non-binary Black Indigenous people of color, namely Jelani Fontaine, formerly of Third Root in Brooklyn, and Belen Berhanu. Sikh pastoral, Sikh ecology poem. So how does candy spill? Is it this way? Stare at the sky as my chart results record blood levels, peach-laden, cherry lacquer, lilac blossom marathon, more at a windowsill on any almost evening in. Wait, what month is it? When statistics play, when the masks are forgotten, there'll be more of us we'll have to teach. And catheters are ivy. Monstera fenestration consoles when you're on hold with the pharmacy. Again, you grow impatient. Breath boasts spasm, spontaneity, and apricot-colored view. Skin scales. Skin fails. Fish gut gratuitous inflammation. Or how about that hippo rhinoceros hybrid unfurling knuckles into your neck. Yes, your dog will curl in the canyon of your shoulder. No doubt, your cat can scale the ridge of your couch overlooking a lakefront of laundry. When do you teleport to your ancestors' palm softness for a dizzy haven? When in high pain, that must be your default place, huh? Okay, do train tracks thrum aura into a yacht call? Are you the wolf howling gut punch scurrying to the toilet, or are you just the toilet? Is it kidneys? Again. And what of your riverbend back? And what of blood rains from your second, third, fourth, fifth surgery? That was totally Jupiter, harpooning into Saturn's rings, and now there's leopard print welts all over your abdomen. Is your body the costume? Or are you just the impersonator? Unhuman. Sometimes forceps are rotten tulips. Actually, sometimes it feels like you are the dead bouquet just kept around from a good occasion. Oh, sweet memory. Oh, dehydration of the moment storm aftermath abandoned. You breathe a fleet of weeps or cumulus cascade depending on the day. How you lily pad from one scowl to another missed meal. Speaking of frogs, is your skin still inflamed? How you raindrop, how you quietly pebble, how you can evaporate as thin as air. High pain might not be cosmology, but oh my kindreds, how you end up seeing all the stars anyway. So I feel like when it comes to poetry, that 61% of people with COVID, disabled folks who have lost employment, that would be me. Nobody wants to do virtual anymore at all because the pandemic is over. So let me be clear, there is no post-pandemic, like there is no post-colonial. There is ever-present gruesome pandemic, just like currently there's ever-present colonial occupation, right? Free Palestine from the river to the sea. Yes, from Palestine to the Philippines. Let's stop the US war machine. And so there are art spaces, political spaces, your hottest queer parties that do not want a mask. And somebody had wrote me an email. I've probably lost about $40,000 this year being booked, and then people refusing to have COVID protocols, people refusing for participants and panelists to mask, people refusing hybrid. So what this does, what this ableism and long COVID collaboration does, it collaborates with white supremacy, it collaborates with cis supremacy, it collaborates with anti-Blackness and racism, right? So just to be clear, if we were poor and lacked resources as trans people and as disabled people, prior to COVID, it is only amplified multiple fold. And I get these emails that say, we are mask friendly, which means you can mask. But looking at the statistics, other people won't. Sick ecology and denial. I just got back from an arts residency, and that's what the artistic director sent me. From another art space run by white people, white cis people, during orientation, how about that fall foliage? As writers paint and painters kick pebbles up a dirt road, me, still standing 6 feet apart just so I don't end up dead under earth. Everyone else seemingly breathes air, like it won't knife them, like a cough isn't a funeral's interlude. And we are shown a pool once built by Edna St. Vincent Millay herself. How many spooned out sloppy kisses did she give in the deep end? Did she float belly to the sky to shake the feeling of not being believed? Ivy and algae scaled up concrete on her pool where arms previously paddled in sunlight. I think about my uncle, my tito's lungs swamped by virus, and how his biceps flexed to reach for air for his wife, how the sound of his cough wades in my cousin's dreams now that he's dead. And supposedly the pandemic is over, and it isn't lost on me that I am on stolen land bought by a feminist white disabled bisexual poet icon who had damaged nerves in her spine. How she counted on surgeries as much as stanzas to stay alive. How hospital gowns wrinkled by glitches of her chronic pain, of course, none of this in the orientation packet is mentioned. Dear Edna, the place of your namesake currently has 0 COVID protocols that would actually keep you safe and alive if you were here in the global pandemic today. Would you be with me, nah? Scared to share a meal? Coughing candescence. Girl, would you be like me? Stumble in at 3 a.m. for an ice pack and a little snacky. When the word creative retreat is said on a cellular level, would you just stay in your studio like me and only come out for meals, perpetually isolated? Would you flicker whimpers with balled up fists? Would you fear buzz in the persistence of the bees in your garden? I do not pretend to weigh statistics, and yes, what is more bisexual than fall leaves in every color? What is more sick than a sunflower bowing the crook of sunset? How many poems did you write, dear Edna, that made you determine that enough was enough? What poems did it take for the pastoral of your body to decide, yes, we must protect ourselves at all costs? Thank you.
Wow.
I think I want to call into the space that's really important for me. When we're talking about long haul COVID and the impacts of COVID, I want to recognize how the medical complex, the state complex, is imposed, like accelerated trans antagonism, white supremacy, right? Accelerated poverty. And for me, these dialogues pre-COVID are in direct correlation with the movement of disability justice. And I know that's a buzzword now in everybody's mouths for grants, right? But for me, I think it's also important to name that disability justice was founded by Black people, Black queer people, and Black poor people. And so that means for me, Sins Invalid, namely Patricia Byrne and Leroy Moore, founder of Crip Hop, Crip with a K, not with a C. And I think it's important also to call into space Black, Indigenous, non-Black, POC, trans, and non-binary people who have been doing disabled work, sick work, advocation for people with COVID and long haul. And for me, namely, that includes Jimena Lucero, trans femme Latin from Health Justice Commons. That includes Walela Nehanda in this room today, Saray Jarrell Johnson, Jelani Fontaine, and Maxwell Joy Moore. So those are the places that I learned from. I am going to read a poem called To Be Underwater and Holy. So do people know what the term spoon means? If you're new to being disabled or sick and you don't understand spoon theory, it's a unit of measurement by sick and disabled people, people who face chronic pain, people who are neurodivergent. Hey, Kay, how are you feeling today for this meeting? And I'm like, friend, I'm low spoons. That means I am low energy, right? Spoon is a unit of measurement for your sick, neurodivergent, mad, crazy, chronically ill self. So I'm using that term. To be underwater and holy. Every survivor is splendor. Every spoon is sacred. Every cough is an altar on the bend of a rib cage. Every cane, my loves, every cane is a drum calling into this earth. And you will be told by your own queer, trans, and radical community that you are not worthy of a party. That you will be told you are not a celebration. So why exist at all? Because breath is an exhausted ship lapping the wind. Because your muscles are the fatigue of a sunset. And when our bodies are carnal waves collapsing, remember, together, we can find the shore. Together, we can rock and wave and rest and float together. We need to move together. Together, we can rupture veins into storms, and together we can be the grit as promising as a sound of shells. Now, our lineage tells us there will always be land and ocean in our bones. So after every shift of tide, beloved, no matter the catastrophe, please hold on if you can. Here's a promise, huh? Dare to press an ear against my chest, and on this love, we'll grow scales for every current. We'll part every sea like scripture. So I'm going to perform one last poem, and this is a trans poem. Yes, I want to also uplift. I cannot emphasize enough that if an organization or event does not include accessibility, that they are buying into the bootstraps, right? That they are welcoming the colonizer's language, that they are assimilating into white supremacy and cis supremacy, abled supremacy, wealthy, rich, elite supremacy. The purpose of collective care and people science, as Health Justice Commons would put it, is that we have a right to share and create a collective where everyone can come to the table. And if this table isn't working for us, fuck the table, we'll build something else, right? So my last poem is the way that trans people are dictated in the body. And it's called Post-Mortem Story, or How Archaeologists Might Fail Me, after Lurival Becerra de Sa and after Lady Sao. Content warning for trans violence and mentions of unaliving. So take your beat on that. More than my femurs will be found sprouting below a lilac bush. My left front tooth, a wavy millimeter. My pelvic bone, an avenue and U-turn. Archaeologists are trying to study trans bodies. They might find a body like mine, one like burnt clay pots. My cheekbones compressed by loam, my tibia long as a brittle bow that once kicked up to the wind to argue about my bone dust before I'm actually dead, to plot silhouette of my afterlife, like video game. Did you think the schematic of a human is only calcium? Did you know trans people recognize more than marrow? Did you know that this state or documents or empire could never jot down our plot twists? 80 policies, many, many more introduced in law say trans children can't play sports, can't mouth truths to doctors. Congress wants so badly to get between our legs, to dictate how a child to run. What indicates triumph? So obsessed with wonder-bred cis straight white lives to harangue young and to forecast the dead. Sacrum and tailbone are not some confetti. Trans people on Reddit, they make psalm on keyboards, obliterate possible pencils from our bones. One said he would rather swallow flames. His sinew turned soot so archaeologists don't fumble pronouns even after we've become our own blossoms full of blood. I do not blame them when I am dead. Maybe I'll drift out to the sea. My shoulder blade bedazzled with anemone, my collarbone filament swerved on the rising tide by some bashful lovers at sunset. A constellation of quiet carrion nestled in the blushing shimmer of a wave, and one will say to the other, "Hey, baby, do you see that sky? I made that for you." And by then, we will all know that trans is in everything, so continuous. It's silly to wage our wakes at top speed. Trans people have always been interstellar, becoming upturned comets when banished in outpatient psych wards, family reunions, a doctor's medical office, a junior high history book, of course. This is all speculation. A lament for a future only maybe habitable. And this hot earth is turned into a corporation. Fahrenheit slaughters bird lungs at border walls, deer droughts next to your police state patrol brick. But the concern, hundreds of years after I'm long gone, is if I'm only male or female. Let's be honest, you aren't ready for the future. Won't have enough energy to even dream up my bones. As much as you want it, what's trickling isn't actually our blood yet, because you can hardly even pronounce the piss of me in the next stall. Thank you so much, Trans Equity and Long COVID. Please remember that accessibility and disability justice centers trans people, centers Black, Indigenous, and POC people, centers migrants, and centers poor people. When we're talking about collective care, please create networks together, independent of the state. The state, as we know through long COVID, will not leave us. So we're creating those systems together. For more resources, please go to Health Justice Commons, as well as to Sins Invalid. Thank you so much for your time and for your spoons.
I adore you, and always feel so lucky to be able to have you in all your talent. It's so hard feeling to hear your and to see you. Thank you. So many questions. So many people who are living with long COVID are not believed. And what is the narrative that we should have about this when people don't believe us?
Do you want to start? Sorry.
No, you go for it, JD.
Well, I think there's a couple of things to remember. The reasons that we're not believed are not the reasons that people think they're not believing us. So even as we may be like struggling as individuals and pods and networks to get what we need to get, I think we need to sort of resource ourselves with our understanding. We're not believed because of misogyny and patriarchy and racism. Like, I wanted to point out the complex chronic conditions that are such a core part of long COVID, even though there's many other things with long COVID that aren't. These are the disbelieved conditions that are now part of a larger, often disbelieved conditions. And why are they disbelieved? They're disbelieved because they're understudied in everybody, but especially trans people. But to the extent they're known at all, they're majority documented as being in women, right? And so they're seen as not real because women aren't trusted, and they don't fit the stereotype of what an illness is supposed to be, which is never true. But it's supposed to be, an illness is something you go to a doctor, they give you a test and tell you what you have, and then they give you a treatment, and then you get better. So it doesn't fit their situation. So these things is all their problems that are put on us when we're trying to get care. So when we're being disbelieved, I think there's what we do to resource ourselves, and then there's what we do to get what we need. So resourcing ourselves is, and I believe it's so important that we connect to, whenever possible, to people who have what we have, in part because someone may have found a better doctor, right? And then we can fight our way to, or say, avoid this one, right? We can learn from each other, right, what not to do, or what to try, or what to do. It may not always be enough, but we can at least have support to try and find a strategy from those who have, gone before us that can figure some things out. When we find our way or are able to access a medical provider, how do we talk to them in a way that won't immediately shut them down, but that we may have to do in order to get what we need? So there's like strategies and like tactics for kissing up to doctors in ways that get us what we need. Sometimes it has to do with being very clear why we're here, bringing someone with us as our advocate. Because if a doctor doesn't want to give us a test, you say, could you record that in my chart? And then they're like, oh yeah, well, okay, we may as well just give you that test. Like things that can turn around like that. There's a lot of sort of strategies and tactics we shouldn't have to use that may help us get through to get what we need. There's support groups of people with long COVID online that can be helpful. And the biggest one that we were sort of, a lot of long COVID activism grew out of, shut down. But for example, there's a Discord based one now that people are using to connect with one another. There's different groups that are on, if you're on a particular platform, there's probably people with long COVID gathering there. And then you're always welcome to contact us, and we can give people resources to the best we know of, what's out there for care.
Thank you. As we are talking, like a lot of people are commenting about how they are not believed, right? Mm-hmm. And Sari, how do you think these affect people? Like not the long COVID, but the fact that they're not believed.
The medical sort of complex and providers need to listen to patients. It's not acceptable. And I think what JD was saying about strategies of sort of how to communicate with providers. I think the bringing a patient advocate, bringing somebody with you. Trans communities have a long history of mutual aid and support, and we talk to each other about the doctors that will serve us and care for us. Providers need training. They need training in working with us. There needs to be standardized training around how to work with trans communities effectively. We did a little qualitative study, and we talked to a bunch of patients. And one of the things that they talked about was this idea of seenness. Like, what does it mean to be really seen by a provider? And I feel like it was a theme that kept coming up over and over again. Because, sometimes we'll think about gender affirming care, not hormones or anything, but just, care that affirms us as trans people. Like, but what does it really mean to be seen by a provider? And I think that's some of what this conversation reminds me of, and the larger dialogue, I think, in medicine sometimes is around patient-centered care. And if providers really want to be centered in patients and put their patients at the center, then there's like a lot of training that we need to do. So
Thank you.
Also, I put this in the chat too, but I forgot to recommend this book, The Long COVID Survival Guide, which has stories from people with long COVID and suggestions and companionship, basically, to ungaslight each other, that we recommend, that could be in some libraries. And there was a program that we may try to help restart, of like people can donate a copy to someone else who needs it, like on a little spreadsheet, to get more people copies.
Thank you. I'm gonna keep going for a couple of extra minutes if that is okay. If you need to go, just go. But I think like it is important to use a little bit of extra time. I am having so many questions. Sorry, from the research point of view on healthcare for trans people, right, which is so poor and little. What are some of the things that should inform how we create long COVID for care specifically for trans people?
The study that we did, and that should be the first in many. We need resources that are going to be leveraged to contribute to understanding what the needs are of trans folks who have long COVID, right? What are some of the things that would make life easier, that would help support, that would help with access issues in care, that would help for different medical treatment that might be needed, and those kinds of things. So, I think we just need more information so that we can give it to the system and sort of say, these are the needs. Like, I think, JD, you're working on a needs assessment. Like, what are the actual needs? And then that helps us to push with the advocacy to be able to, advocate with medicine. The specifics are like, how long, are symptoms lasting? What are the kinds of symptoms that are occurring? Some of the data I showed you, that plot where people were having multiple different types of symptoms, that's a really important piece. It's not like people are, having one thing. Understanding what the experiences are of people, and how we can best support.
JD, in the article that I mentioned at the beginning this morning, age was really surprising to me that it's actually younger people and people in the 30s and 40s that are finding themselves with symptoms of long COVID. Is there anything else that you want to add to that? Because I thought it was really remarkable.
It's very atypical for young people to suffer memory loss. With me, I'm about to turn 56, and I know that since I've had COVID, I have trouble finding words, and I have more brain fog. Treatment has helped. I take the MCAS treatments that I take, including cromolyn sodium in 2 different ways, and kenitophin in 2 different ways, has reduced my brain fog, and low dose naltrexone has helped me a lot. But also I'm 56, so my memory may be declining a bit. With younger people, it's really striking. That's less sort of in the natural course of events. On the flip side of that, a lot of older people who actually are more likely to get long COVID if they're elders just get told, well, you're old, you're lucky to be alive, you survived COVID, who cares? You don't have long COVID, you're just getting old. So I think it sort of cuts both ways. People who haven't been chronically ill before, or don't think they're around other chronically ill people or disabled people, don't recognize that we do everything we can till we can't. So people will be like, well, I wouldn't know if lots of people had long COVID. Like, I'm still at work and seeing people at work, and my friends aren't talking about it. Well, your friends are going home after work and crashing, or they're going home and they're snapping at their kids and feeling really bad about it because they're so tired. I've got mild conditions of this stuff, but I can't work a full day and then parent and make dinner all at once. We are so behind in a society in not recognizing and so stigmatizing what it means to be sick that we can't even honestly say, you know, I can't remember stuff and really look at that and think about what that may mean, because we may lose our jobs, we may lose our partners. You know, one of the main things that happens, particularly with people who have ME, is their partners leave them. People with long COVID, people leave, you know, and I know all relationships are complex. And if we admit what's going on with us, we suffer more loss, and it's stigmatized, you know. So that's why, honestly, I'm not trying to single out the HIV community, but I find, we write about this, me and Nana Khanna from Positive Women's Network, right, one of the last chapters in here, and we talk about there's stigma about disability in the HIV community, in part because people have so much to lose, and there was so much fear, and is so much fear of becoming sick. Now in an era where everyone's supposed to be doing well, you know, it's not okay to be sick or need other help. That hits hard with a lot of trans people, because, you know, a lot of trans people have HIV and a lot of other comorbidities going on, but everyone's supposed to be doing fine and like mountain hiking and stuff. So I don't know if I answered your question, but those are some of the things.
No. Yes, but you did. Part of my poor responsibility around my own health around COVID and the health of people that I care for, or people in general, have been masqueraded by the fact that, you know, I need a social outlet. I need to be with people because, you know, I have COPD and emphysema. You know, every time I get COVID, it's like really, really bad. But I've been just putting that in my head, saying like, you know, I need to socialize. I need to, you know, have social encounters. What are things that people can do to regain community in a responsible way?
I have a lot of sex with COVID safe people, and we have protocols, and we have a Google Doc. I mean, I'm a unicorn, not why you may think I'm a unicorn, because out the end of my street, there's an outdoor testing site where I could get a PCR test. So that figures into my protocols and the people who stop by on their way to or from my house to get their PCR test. PCR tests are much more accurate. Most rapid tests right now, many rapid tests are not showing that someone has COVID until they're 4 days into their symptoms. So they're not that very useful to see if one may not be risking others, you know? So, but my COVID protocols, which would go for it's not just having sex, it's like having a meal with someone or being unmasked. People need to be wearing masks for at least 5 days anytime everyone in their home or they live alone has to be doing the same stuff of wearing masks anytime they're in an indoor public location or outside near other people. And they have to use ideally PCR tests or multiple rapid tests to do the best guess possible before getting together. And then right after can be important too, because if there is a risk of exposure, I'm going to want to start on Paxlovid and metformin treatments early on and find out, you know. So we also have extra Paxlovid on hand. So get Paxlovid, which is a 5-day treatment for active COVID infection, which in one very big good study reduced risk of long COVID by 15%. To get Paxlovid, you just need to, one can call, like here in New York, you can call the city 212 COVID-19, or other places, you know, are going to urgent care, or for people with health insurance that can go to a provider, and you say, I tested positive at home on a rapid test. No one says, show me the rapid test, or you can have a photo of a rapid test. So I believe it's important for people to stock up ahead of time and have what you may need at home before you need it, because also your friend may need it, your lover may need it. So have your supplies at home. So that's also part of the protocols, like being prepared. People develop agreements for, you know, our different levels and types of relationships, agreements for what it takes for air sharing are not, I'm in a state where I feel like I can lower my risk substantially. There are people who can take no risks. I want to acknowledge that. People who have distinct medical conditions, distinct levels of immune suppression, they have to really eliminate all possible risks of encountering COVID. I have a kid in public school. My kid goes masked every single day. My kid is like a mask champion, and also lives half the week in another household with a parent who doesn't consistently mask. So there's only so much I can do, but I can tell people what my protocols are. I can find out what their protocols are. and maybe we can do a thing together. You know, it can happen.
Last question, what causes long COVID?
That's a great question. And, I think we don't. I think that's really a great question for research, and it's something that we all need to be investigating. There's sort of speculations, and JD probably could hop in on things that you know about, but I from my read of the data, it's really just not well understood.
It's a combination of things, and there's many long COVIDs, but one leading thought is viral persistence. It's not the same as HIV, but we know the reason people have to keep taking antiretroviral treatment for HIV is that the virus is sequestered in parts of the body and can kind of regenerate and come back if you go off treatment. That's not necessarily what's happening with COVID, but there may be elements of the virus or parts of the virus that are stimulating an ongoing response. Longer courses of treatment is now being studied in long COVID, looking at 20 days. So there's viral persistence. There's organ damage. There's things that COVID itself can do to parts of the body. There's damage to the vagus nerve, which controls autonomic things like that affect dysautonomias and other body functions that seemingly are unrelated. And then it could kick off autoimmune conditions. So let's say it is viral persistence and we find out a way to wipe out all the viral persistent harms. Someone, though, may now have autoimmune conditions that change the way our body reacts to itself and to perceived pathogens or threats. And then there's also reactivation of dormant viruses like Epstein-Barr virus, which we know causes mono, but we know also now can cause is underlying multiple sclerosis. Epstein-Barr virus is really, really common. Almost all or all of us have it, but it's not active. So COVID reactivates it in a lot of people, and so then you can have the harms that are caused by Epstein-Barr virus that can trigger things like ME. There's a lot of infection-associated chronic conditions like ME that can be either triggered by long COVID or by the Epstein-Barr that's triggered by the COVID.
Thank you all so much for such an amazing conversation. We have to come to an end.
Thanks to you,
No,
Cecilia.
thank you, Cecilia, for hosting and everybody for bringing us together.
Thank you all for being here. Please make sure that you take care of yourself, and I see you in the next one.